Anemia. Anemia is said to be a condition where it has been defined as a hemoglobin concentration is decreased in the blood, and it is usually at below the lower limit of the normal range of the particular age and sex of the individual when it is considered. So usually the normal range, that is the lower extreme in an adult male, it is usually 13 grams per deciliter, whereas in females it is 11 grams per deciliter, and it also varies amongst the newborn in the newborn babies when compared to that of the adult, since they have a fresh blood which has been recently synthesized. They have a higher HP level when compared to the adults. Newborn babies usually have the 15 grams per deciliter, which is taken as the lower limit at the time of birth, and usually this high amount of hemoglobin in newborn babies, after 3 months it starts reaching to the normal level as that of an adult, where it begins from 9.5 as a lower level per grams per deciliter. So this is the normal range of anemia, and so anemia is defined as hemoglobin concentration in the blood below the lower limit of normal range for age and sex of an individual. Coming to the pathophysiology, how anemia develops. Usually when there's the level of the hemoglobin has been decreased in the blood, then this hemoglobin, as it also has a function of carrying the oxygen to the circulating blood as well as different tissues, there's also lowered oxygen carrying capacity as hemoglobin is associated with blood in the blood, and then this results in certain physiological mechanisms which adapt to this lowered condition of the blood, in the lowered concentration of the blood in the oxygen, and this mechanism is known as compensatory physiological mechanism. So compensatory physiological mechanisms, they compromise increased oxygen from the hemoglobin, and they also compromise increased blood flow to the tissues, as well as they also help in maintenance of the blood volume, and they cause redistribution of the blood flow to maintain cerebral blood supply. So these are certain compensatory mechanisms which have been adapted for lowered oxygen supply or lowered oxygen concentration in the blood. Then this compensatory physiological mechanisms, eventually they result in tissue hypoxia, and this tissue hypoxia, it varies among the various organs and tissues in the body, since there are certain organs which require high concentration of oxygen in the body. So this tissue hypoxia, it varies, whereas it requires high amount of oxygen in certain organs like the central nervous system and the lung tissue. So this tissue hypoxia varies among various organs and tissues in the body. So this is what is this explains the pathophysiology of anemia. Next, coming to the clinical features, mainly it depends on 4 main factors. One is the onset of anemia. So depending on the speed of the onset of anemia, usually we can describe the clinical features. If it is a rapid onset anemia, then there are more number of symptoms, whereas in slow onset anemia or mild onset anemia, we see the symptoms which occur or manifest slowly in a patient. So this is one of the factor for the clinical features to develop in an anemia. Next, coming to severity of anemia. Usually if the anemia is severe, the complications are also severe, whereas in mild anemia the complications are mild, that is there are only few signs and symptoms which can be observed. In sometimes in severe anemia, we see that the patient might not also be being manifest with the particular clinical features which are most important cardinal signs, such as pallor of the mucosa or skin or the conjunctiva, as well as any change in the shape of the nail, such as known as koilonychia. So these are certain manifestations which are being shown by anemia, and these manifestations might also not be shown in severe cases of anemia. Coming next factor is age of the patient. Usually young patients, they respond to anemia very well because of the compensatory mechanisms and because of the dietary intake which they take. Whereas coming to elderly patients, when anemia develops in certain compromised conditions, when the patient is already a cardiovascular impaired patient, then there is more chances that the patient might not recover, rather it might cause more degrading of this body. So this is one of the factor which also helps in showing the clinical features, age of the patient. Next, coming is a hemoglobin dissociation curve. As hemoglobin has a capacity to carry oxygen to the other tissues in the body, in anemic conditions, we see that hemoglobin, it readily dissociates the oxygen. That is, it spreads the oxygen and releases to the tissue. This results in an hemoglobin dissociation curve. So a graph of hemoglobin dissociation curve is being shown in the picture, which shows that the oxygen partial pressure is being plotted against percentage of the saturation of the oxygen. And this hemoglobin dissociation curve usually gives a sigmoidal shape of the curve in an anemic patients, which means that it is mainly because of the cooperative binding of the oxygen to the hemoglobin. So this is one of the factor for the clinical features to develop in an anemia. Next, coming to the symptoms, usually we find that the patient most commonly becomes tired and shows easy fatigability, that is easily becomes weak and cannot put any efforts to work, and there's generalized muscular weakness also associated with this. It could probably be because of the impaired oxygen supply to these muscles, and they show impaired functions or alterations in the functions, compromised functions, which could result in generalized muscular weakness. Other than that, patient might also show lethargy, headache, and in severe anemic patients which have been associated with certain cardiovascular disease, we see there's also cardiac failure in such kind of patients, and it might also result in angina pectoris. Anemia not alone, but in association with other secondary complications might result in angina pectoris. Other than that, there's intermittent claudication can be seen, as well as confusion and visual disturbances. These are certain symptoms which can be seen in an anemic patient. Next, coming to the signs of anemia, the most important feature where the subject is to be observed for presence of pallor. That is this paleness in the skin, paleness which can be observed in the skin, mucous membrane, and conjunctiva of the patient. So this is one of the important feature which is to be done in the subjective examination when the patient approaches at the first visit. Next, coming is the cardiovascular system. Usually we see there is a congestive heart failure or otherwise collapsing pulse or tachycardia, which can be associated with the cardiovascular system, which are the signs in anemic patient. Next is the central nervous system. We see that the patient might not respond properly with the the patient might be facing with the dizziness, tiredness, or otherwise giddiness also. The patient can may become faint and unconscious also sometimes, and when anemia reaches is being associated with the central nervous system. Then the other features are ocular manifestations. Suppose the patient is already suffering from any vascular disease, then these ocular manifestations, they manifest in the form of retinal hemorrhages. So this is one of the ocular manifestation in anemia. And next coming is reproductive system. Usually it affects some females which manifests as menorrhagia or amenorrhea. And also we find another feature is loss of libido in reproductive system. Next, coming to the renal system, the concentrations of the kidneys are being altered. Other than that, since blood is also being carried to this renal system, this might also result in compromised functions of the kidney when anemia involves the kidney. Next, coming is the gastrointestinal system. That is, the patient might complain of nausea, vomiting, and even constipation like problems when in severe cases of anemia. So these are certain signs of anemia. Coming to the symptoms of anemia, showing a picture representation. Eyes, usually we see yellowing of the eyes, usually in the conjunctiva, and in the sclera also we see certain such kind of symptoms. Coming to the skin, usually the patient gives a complaint of paleness, which can also be observed on subjective examination, as well as on touch. That is, a patient can be seen that this change in the thermal conditions, that is coldness, can be seen. Along with that, yellowing of the skin can also be seen. Coming to the respiratory system, patient might complain of shortness of breath, and muscular weakness is also one of the finding. And intestine, when observed, it shows change in the stool color. And coming to the central nervous system, usually we find that the patient shows fatigue, dizziness, and fainting. Blood pressure, usually the patient complains of, usually it can be observed when a blood pressure is being measured, it shows a low blood pressure. That is, patient might be hypotensive. Coming to the cardiovascular symptoms, they are the palpitations, rapid heart rate, chest pain, angina pectoris, as well as heart attack. These are the certain features which can be observed in cardiovascular system of the anemic patient. Coming to the enlargement of the spleen is also, that is splenomegaly, can also be as one of the finding of anemia. So these are certain symptoms which can be observed. Among that, fainting, chest pain, heart attack, and angina are the most common and severe anemic features which can be observed in a patient suffering from anemia. Coming to the investigations, usually the patient clinically is examined for paleness, as already described, in the skin, mucous membrane, conjunctiva, and other than that, for the changes in the temperature, body temperature can also be seen, and presence of koilonychia, spoon-shaped nails can also be examined, and any changes in the tongue color or presence of glossitis is also being seen in a clinical examination. Coming to the laboratory investigations, the most commonly required examination is hemoglobin estimation. Since anemia is mostly because of lowered hemoglobin level, hemoglobin is being examined first. And the most commonly preferred method is cyanomethemoglobin, which is also abbreviated as HICN, which is being employed using Drapkin solution as well as spectrophotometry. So what happens in this investigation is that hemoglobin which is being collected from the patient is being mixed with Drapkin solution. Drapkin solution, it is a solution which comprises of ferricyanide and cyanide. So as hemoglobin has an affinity to bind the heme part of the hemoglobin, that is the iron content, it has an affinity to bind to that of the ferricyanide which is present in Drapkin solution. Both of them together, they bind and result in the formation of methemoglobin. And this methemoglobin has an affinity to bind to the cyanide which is present in Drapkin solution. And this results in the formation of cyan-methemoglobin. So this is what happens in a hemoglobin estimation. So this cyan-methemoglobin which has been formed with the help of the ferricyanide and cyanide which is present in the Drapkin solution usually has a property to produce a pigment. And this pigment it provides in one of the feature to identify the hemoglobin presence of hemoglobin concentration in the blood with the help of using a particular instrument known as calorimeter, or otherwise known as spectrometer. So this calorimeter or spectrometer usually measures the intensity of the color which is being produced by cyan-methemoglobin. And this provides this also other than the color, it also provides the estimation of the hemoglobin which is being present in the blood. So this is one of the method, and other than spectrometer and calorimeter, there have been other instruments which have been already present with processed colored plates which help in observing or matching the color with that is being produced by the cyan-methemoglobin with that of the standard colored plates, and helps in giving the observation or of the hemoglobin concentration in the blood. So the other methods used for hemoglobin estimation in a regular basis is Sally's method, which is a more simple and inexpensive method. So this completes the hemoglobin examination. Next coming is a peripheral blood examination. This is usually done to observe the blood cells which are being present in the blood, and which also helps in identifying the total number of blood cells, giving the type of anemia, whether it's a microcytic anemia or a macrocytic anemia or a dimorphic anemia. So peripheral blood examination describes the types of cells, that is the blood cells which are present in the blood. Among them, most commonly used stains, they are the Romanowski dyes, which comprise the Leishman stain, May-Grunwald's Gimsa stain, Jenner-Gemsa stain, Wright stain. So these are Romanowski stains which are most commonly used for the peripheral blood examination, where this blood smear, it is evaluated usually at the junction of the body and the tail in the blood film which is being produced. So this blood film, it is usually seen in the picture which is being stained with Wright-Grimstad stain. The blood film is a drop of a blood which is being collected from the patient is being placed on at one edge of a slide, a microscopic slide, a rectangular slide, and this drop of blood is being dragged or pushed forwardly with the help of another microscopic slide, and this in turn, this smear which has been created with these two microscopic slides helps in formation of a tongue-shaped smear which is produced on the microscopic slide, and this smear is being stained further depending on the preferred stain, whatever is being preferred by the technician, and this is the staining procedure is being followed according to the manufacturer's instruction, and then once the staining is done and the slide is dried completely and is ready for observation under a microscope, it is usually the area where exactly the microscopic slide is supposed to be examined is at the junction between the body and the tail. So as the tongue-shaped smear is being produced on the microscopic slide, this tongue-shaped smear usually consists of body, head and the tail. So, and the most common, most importantly, and this is being observed at the junction of the body and the tail in the smear. So, this is what happens in the peripheral blood smear examination. So, these are the investigations. One is hemoglobin estimation, and the next coming is the peripheral blood examination, which are the most common lab investigations to diagnose a patient with anemia. Next, coming to the abnormalities in the erythroid series or of the cells, usually which is observed in a peripheral blood smear. Usually we can observe that there is variation in the size of the blood cell. It could be a normally the size of a red blood cell usually measures 6.7 to 7.7 micrometers with a mean of 7.2, and it is biconcave in shape usually, with a peripheral redness which is being produced by the heme, and then central it is paler. So this is what is the normal structure of a red blood cell. But we see that in an anemic patients usually there is variation in this size of the blood cell. This variation is known as anisocytosis. So increased variation in the size of a red blood cell is known as anisocytosis. So this anisocytosis could be a macrocytosis, microcytosis, or dimorphic. That is, we see larger size of the cell in cases of macrocytic anemias. Amongst them, most commonly given illustration is a megaloblastic anemia or hemolytic anemia. Next coming is a microcytosis, that is then the normal average size of the red blood cell, there is no smaller size, and this is known as microcytic anemia, and this microcytic anemia is usually seen in iron deficiency anemia. Next coming is the dimorphic anemia, that is we observe both the morphology. Dimorphic, when we spread the word dimorphic, it is di means two and morphology means two kinds of morphology. And that is we can see that there is presence of macrocytic as well as microcytic anemia, and this is a very rare condition which is most commonly seen in aplastic anemia. Coming to the variation in the shape, that is any variation in the shape is known as poikilocytosis. Usually we define poikilocytosis when there is increased variation in the shape of the red blood cells. Usually we find that the normal shape is a biconcave shape, but here in red blood cells we can observe that other than the biconcave shape, it could be in various shapes, such as sickle shape or split-like cell, or with ragged borders, or extensions of the cytoplasm can be seen. So these are the various shapes which are being described in the further slides. Next coming feature, an abnormal feature in peripheral blood smear which we can observe is inadequate hemoglobin formation. This inadequate hemoglobin formation is known as hypochromasia. Usually we see that the intensity of pink staining of the hemoglobin in a Romanowski blood smear, stained blood smear, it gradually decreases from periphery to the center of the cell, as we have already discussed, that the periphery of the cell shows dark pink color or dark red color in appearance, whereas in the center it is pale. So this is a normal feature of the red blood cell, but whereas in a hypochromatic anemia, we see that there is increased central pallor than compared to the normal paleness which is seen in a normal blood cell. So there is a picture which shows the increased central paleness in an hypochromic anemia. Hypochromic anemia is also an illustration can be given of iron deficiency anemia. Next coming feature is compensatory erythropoiesis. So compensatory erythropoiesis includes certain conditions such as polychromasia, that is the red cells which have more than one color, that is usually they produce red color or purple color depending on the stain which is being used, but more than that, the other colors like blue color which can be produced, or reddish purple or grey color can also be produced. Next coming feature is the erythroblastomia, where we see that the presence of nucleated red cells which are present in the peripheral blood smear, which explains that they are the erythroblasts or the normoblasts which are actually further mature and give rise to the red blood cells and further other blood cells. So there is presence of these nucleated red cells in the peripheral blood smear is known as erythroblastomia, and this is most common feature which is being seen in a newly born baby, where a notocaudal caudal blood which is being collected shows the presence of these erythroblasts and normoblasts which usually further give rise to the red blood cells. The next compensatory erythropoiesis is a punctate basophilia or basophilic stippling, where we see that there is diffuse and uniform basophilic granularity in a cell. Usually the granules, they are usually localized to a particular area in a cell, normally in a general blood cell, but whereas we see in a condition such as punctate basophilia or basophilic stippling that there is uniform and diffuse, that is the cell almost might be showing presence of basophilic granularity. The next other cells are known as Holly-Jolly bodies, which are the purple nuclear remnants, which are usually seen larger in size when compared to the basophilic stippling, which shows that basophilic granularity, and usually it appears in single. So these are certain examples or illustrations for compensatory erythropoiesis. To maintain the lack of the blood cells in the blood, these are the conditions which are being adapted. So there is a picture showing polychromasia, showing more than one color. They can also be seen a dark bluish color as well as violet color in the picture. Next coming is the Holly-Jolly bodies, usually larger in size, showing granularity as that of the punctate basophilia. Coming to the miscellaneous changes which we usually observe in an anemia, they are the spirocytes, which are usually seen as spheroidal rather than, as we have already explained, that the red blood cell consists of biconcave shape, but here we see that there is presence of spheroidal shape red blood cell. Whereas in schistocytosis, we see that there is a fragmentation of the erythrocytes. Erythrocytes, they fragment and result in the formation of microcytic cells, which is a feature of iron deficiency anemia. And next coming is the leptocytosis. Usually we find there is thin red cells. They are known as leptocytes. Next coming the sickle cells, which we see, they are also known as deprinocytes, and they are usually identified with a shape, that is, they give a sickle shape appearance, and most commonly it is a feature of a sickle cell anemia or hereditary anemias. Next coming is the crenated red cells, where the erythrocytes, they show numerous surface projections. It is most commonly seen when there is any damage or in case of injuries, we find such kind of crenated red cells. Next coming is acanthocytosis, where we see coarsely crenated red cells, that is the red cells along with the cytoplasmic or surface projections, they give a coarse appearance. Next coming is the bud cells. They usually have more than one spine, that is, they give a spine-like appearance, so they are termed as bud cells. The stomatocytosis, which they are the stomatocytes which produce a slit-like or mouth-like appearance when observed in a peripheral blood smear. And the last type of cells, they are the ovulocytes, also known as elliptocytosis, which give an oval or elliptical shape of the red blood cells. So these are certain miscellaneous changes are being adapted by the red blood cells. So there is a picture, first picture showing a spirocyte. Next coming is a schistocyte. Next coming is an irregularly contracted cell to adapt to that of the oxygen content on even in presence of irregularities such as when there is improper hemoglobin arrangement, that is of the heme part and the globin part. And then coming is a target cell, sickle shaped cell. In sickle cell anemia, crenated cell showing spine-like appearances, and acanthocyte similarly, which shows a course with spine-like appearances. Next is a bud cell showing numerous spines being erupted from the surface of the red blood cells. Next is the stomatocyte showing a slit-like or mouth-like appearance. Next is the ovulocyte showing an oval appearance. So these are certain miscellaneous changes being adapted by red blood cells in anemic patients. Coming to the red cell indices, they are usually the indices which are being calculated additionally to that of the hemoglobin estimation and the peripheral blood smear. The first one is the mean corpuscular volume. It is usually a ratio of the packed cell volume and red blood cell count, and normal range is 85 plus or minus 8, and the mean is 77 to 93. Coming to the mean corpuscular hemoglobin, it is a ratio of hemoglobin and RBC count, where normal range is from 27 to 32. Next coming the mean corpuscular hemoglobin concentration, which is abbreviated as MCHC, and it is the HP, it's the ratio of HP per deciliter and packed cell volume. So the normal range is from 30 to 35 grams per deciliter. So these are certain red cell indices, and usually we observe in an iron deficiency anemia there is decrease in mean corpuscular volume, mean concentration corpuscular hemoglobin, as well as mean corpuscular hemoglobin concentration. Whereas in megaloblastic anemia, we find all the three indices being increased. So these are the red cell indices. Next, coming to another investigation, that is a leukocyte and platelet count. Usually these are the investigations which are done additionally to observe if suppose the anemia etiology is not being identified with the routine hemoglobin estimation or peripheral blood smear, then these are the conditions, these are the investigations which have to be carried out to rule out the etiology of the etiology or the cause for which the anemia is developed in an individual. So presence of leukocytes, that is the estimation of the leukocyte count, can help us in driving the presence of of patient is suffering from leukocytosis or any kind of decrease in the leukocyte count, such as eosinophil, the decrease in eosinophils, neutrophils, whether it could be a granulocyte or an agranulocyte. So the estimation of leukocyte and platelet count usually helps in observing the underlying cause when it is other than anemia, because in conditions such as pancytopenia, we see that the red cells, leukocytes as well as the platelet counts all have been reduced in number than that of the normal range. Whereas in conditions such as hemolysis and hemorrhagic conditions, we observe that there is elevation of the leukocyte count as well as the platelet count. Whereas in certain infections which we observe, there's increase in the leukocyte count and as well as there are abnormal features also. Immature leukocytes can be observed. So these are the conditions which can help in distinguishing anemia from other conditions. Coming to the reticulocyte, usually it is an investigation done to observe the marrow activity. Since reticulocytes are the cells which are produced during the marrow activity, so observing the reticulocyte count helps us in distinguishing the marrow activity from the abnormal marrow activity. Coming to the ESR is actually a non-specific test, otherwise known as erythrocyte sedimentations test usually, and it is a non-specific screening test which is used as a screening test. Usually it is increased in conditions such as infections and in anemia also it ranges variably among patients. Coming to the bone marrow examination, this is usually done when the underlying cause is other than anemia and it has to be ruled out. So bone marrow examination is done where we can observe the maturation of the hematopoietic cells and the erythropoietic cells. So these are certain investigations done in anemia. Coming to the classifications of anemia, usually they have been classified into pathophysiologic and morphologic. Among the pathophysiology, anemia can be classified. It could be either due to increased blood loss in conditions among this increased blood loss conditions resulting in anemia. They are the acute post-hemorrhagic anemia and chronic blood loss. Coming to the next anemia which is pathophysiologic is anemias which are because of the impaired red cell production. And amongst them comes the cytoplasmic membrane defects, cytoplasmic maturation defects. They are either it could be a defect in the heme synthesis or either it could be a defect in a globin synthesis. When it is because of a defect in a heme synthesis, an illustration of iron deficiency anemia can be given. When it is involving a defect in a globin synthesis, a thalassemia anemia, thalassemia conditions can be given. So these are the cytoplasmic maturation defects when anemias are because of an impaired red cell production. The other coming to the next defects are the nuclear maturation defects. They are most commonly because of the vitamin B12 or otherwise folic acid deficiency. Since these are the factors which are responsible for synthesizing in blood also, and so they are the conditions when there's any lagging. Usually we find in megaloblastic anemia that the nuclear maturation lags behind that of the cytoplasm, which gives an increase in the cytoplasm quantity and decreased or pycnotic nuclei can usually appears. So because of this, megaloblastic anemia is so called because of the presence of such large cells with increased cytoplasmic and pycnotic nuclei. They are known as megakaryocytes. Next coming defect during the impaired because of the impaired red cell production is defect in the stem cell proliferation as well as differentiation. Usually an illustration of aplastic anemia and pure red cell aplasia can be given as an illustration for defect in stem cell proliferation and differentiation. The next common features in an anemia due to impaired red cell production are anemia of chronic disorders, that is anemia occurring secondary to chronic disorders, and otherwise in bone marrow infiltration and in congenital anemias. So these are the few of the anemias because of impaired red cell production. Next coming to the anemias because of the increased red cell destruction. Such conditions are known as hemolytic anemias, and they could be an extrinsic red cell abnormalities or an intrinsic red cell abnormalities. Coming to the next other classification of anemia based on the morphology of the red cells, they can be classified as microcytic hypochromic anemia or normocytic normochromic anemia or macrocytic and normochromic anemia. So this is a classification of the pathophysiologic conditions and the morphologic conditions in anemia. Coming to the iron deficiency anemia, it is the most common nutritional deficiency which is being observed in the developing countries. To better understand the iron deficiency anemia and its clinical signs and symptoms and why it occurs, So it is that is a pathogenesis of iron deficiency anemia can be well understood. One, there's a context of iron metabolism has been explained. So iron metabolism is also importantly required to be understood to know why iron deficiency anemia occurs in individuals. So iron, it is usually metabolized with the help of two factors, that is from the exogenous source, that is from the diet, which is taken in the form of leafy vegetables, meat or liver. Otherwise, iron can also be produced from the senescent red cells, that is the dying red cells, amongst which they release iron, or otherwise it is being absorbed from the existing one. So iron is metabolized in such a kind, and this iron, once it is metabolized, that is either from an exogenous source or from the endogenous source, then this is further absorbed in the jejunum as well as in the gut. So once this is being absorbed, this iron is being absorbed either in the heme form or otherwise in the non-heme form. Non-heme form of iron is better absorbed when compared to the heme form. So the absorption factors which contribute to absorption of iron, they could be citric acid, ascorbic acid. These are certain factors which enhance the absorption of iron from these sources. Whereas they are even inhibitors of iron, that is which alter the absorption. They are the tannins from the which are usually taken from the tea. Other than that, there are certain enzymes known as catalases which also alter the absorption from these areas. Once the iron is being absorbed, it is transported in the form of transferrin, which is an alpha globin bound body protein which is present in a plasma. Once the iron binds to this alpha globin bound, then it is known as transferrin. This is carried in the form of transferrin, and this transferrin, suppose if it is the absorbed iron is not being transported, rather it is being stored, then it is stored in the form of ferrin or ferritin or otherwise ferrous form. Once iron is being absorbed and then it is transferred, it has to be excreted, that is it is supposed to be removed. So excretion is not alone the condition, but rather the cells in the gastrointestine, that is the cells, epithelial cells which lie in the gastrointestine, they undergo desquamation. During this desquamation process, the iron is being excreted. So these are the process how the iron is excreted from the body. Usually we see that compared to a normal adult, that menstruating woman shows more number of excretion of this increased excretion of iron. So usually the iron intake which is to be taken is should compensate that of the losses which are being occurring in the body. That is usually iron can be lost either by excretion or either from the skin. So these should compensate that of the intake of the iron. Usually a daily quantity of iron being intaken is up to 1 milligram. Whereas the iron being lost is from 0.5 to 1 milligram. But whereas that is in a normal adult and a non-menstruating woman. Whereas in a menstruating woman, additional 0.5 to 1 gram is required. Coming to the distribution, so this iron which is being distributed in the form of, can be distributed either in the form of hemoglobin, that is iron in the blood, is known as it is appears in the form of hemoglobin, and it constitutes 65% of iron which is being distributed. Other than that, iron can also be distributed in the form of associated with muscles, then it is known as myoglobin, it constitutes 0.5%. Then the other form of distribution of iron is in the form of heme or non-heme enzymes. They are the catalases, oxidizers. They are the certain enzymes which usually help in transport of this or distribution of this iron. They also constitute 0.5%. Next coming is the transferrin bound iron, that is iron which is being bound to the alpha globin, which helps in transport of iron. And next coming is the ferritin and hemosiderin, which constitutes, they are the storage form of the iron. Usually they constitute 30% of the iron in the total body. So these are the certain, this is the picture of the iron metabolism, absorption, transport, excretion and distribution, and its various forms distribution. So coming to the distribution of the body iron stores, usually once starting from the right side, that is once the oral that is iron is being taken by an exogenous source, that is an oral intake, which is usually the daily requirement is 1 milligram per day. Then it reaches the blood plasma where it combines with that of the hemoglobin, and then it could reach the tissues, and in the tissues if it could reach this iron which is being intaken, it could reach the tissues, or from the tissues which carry iron might also reach the blood plasma. And once this vice versa circulation of this iron occurs between the blood plasma and the tissues, then they are being further processed, that is further metabolism is carried out, and they are being excreted. So the daily amount of iron excretion is 1 milligram per day. So once in the blood plasma, the iron, it also reaches to the bone marrow for the further process of erythropoiesis, where it is being utilized. The bone marrow utilizes 150 mg of iron. Then this bone marrow, it results in it forms certain this iron from the bone marrow is being carried out in the form of other blood cells, and these blood cells, they release the iron into the storage systems, that is the reticuloendothelial system or the mononuclear phagocyte system of the spleen, liver and kidney. So these are the storage systems, stores of the iron. Other than that, bone marrow can also be released directly into the red blood cells, which carry them to the iron stores. So this is the distribution of the body iron stores. Coming to the etiology of iron deficiency anemia, since iron deficiency anemia is a major kind of nutritional deficiency being seen in developing countries, so it is important to know what is the reason for this iron deficiency anemia. Usually iron deficiency anemia could be because of increased blood loss. It can be seen in conditions such as excessive menstruation in reproductive system, or otherwise in repeated miscarriages, or otherwise at the onset of menarche stage, and even in post-menopausal women. This is one of the reason why there is increased blood loss, and otherwise in gastrointestinal conditions, including the peptic ulcers, or even the cancers of the stomach and the large bowel system, or esophageal varices. These are the certain conditions which might also result in an increased blood loss when these conditions involve the gastrointestinal area. Next, coming to the conditions associated with the renal tract, there could be hematuria, that is excretion of the urine, or otherwise hemoglobinuria. So these are the certain conditions which might also result in increased blood loss. Other than that, when nose is involved, that is bleeding from the nose, epistaxis can be given an example of increased blood loss, and hemoptysis, that is coughing of blood, is also one of the illustration which can be given the reason for increased blood loss resulting in iron deficiency anemia. The next other source for the loss, for the reason for iron deficiency anemia is increased requirement. In certain conditions, we observe that there is increased requirement of the iron in the body, and amongst them these conditions involve the spurts of the growth in infancy, that is during growth spurts in infancy there is increased requirement, as well as in a developing child, in a growing child, or otherwise in adolescence, because of the physical activity there is increased requirement. Other than that, the abnormal conditions like prematuration condition also requires a increased iron requirement, and in women we see most common conditions where increased iron requirement is in a pregnant woman and a lactating mother. So these are the conditions which require increased iron. And coming to the other source for the development of iron deficiency anemia is inadequate intake of iron. That is, as an exogenous source of iron is by intake from the food, that is from the diet. So if it is inadequately, when the diet is improper in conditions such as poor economic status or anorexia, or otherwise in elderly people who have a compromised condition with that of the dentition, because problems in the chewing, and also in low socio-economic status, these are the conditions where there is inadequate dietary intake resulting in iron deficiency anemia. Other than that, when the iron is properly being intaken, but rather it is not being absorbed properly from the tissue, then this might also result in anemia. So among them, the conditions which result in decreased absorption of this iron is when there is any involvement of the gastrointestinal area with partial or total gastrectomy is being done. So since this is an area where iron is being absorbed, when any defect is being there, this might also result in decreased absorption. So these are few illustrations and the classification for iron deficiency anemia. Coming to the etiological factors, usually we see females who are in the reproductive period of life, that there is increased blood loss and inadequate intake and increased requirement of iron. So it could be one of the reasons for females in the reproductive period of life for iron deficiency anemia. Next coming is a postmenopausal women. So these women, they usually lose a lot of blood. Increased amount of bleeding is done in postmenopausal period. So And other than that, there's also bleeding from the alimentary canal in these females. So this could also be one of the etiological agent for iron deficiency anemia to occur. Other than that, in adult males, it is usually because of the involvement of the gastrointestinal tract or the gastrouterine or otherwise the uterine tract, which might where there is bleeding and result in certain compromised conditions, or otherwise it might involve in the nose by epistaxis and in the lungs by hemoptysis, that is coughing of blood. These are the certain conditions which are involved in adult males resulting in iron deficiency anemia, and it is a very rare condition for to occur in males. And in infants and children who are inadequately intaking of iron from the diet can also be one of the reason for development of iron deficiency anemia. Coming to the clinical features, usually iron deficiency anemia is already described. It is more commonly in women, since the women have exceedingly bleeding, excessive bleeding when compared to that of the men, which is not one of the property of which is not one of the physical activities in men. And other than that, so women are more commonly affected when compared to men, and the age factor is usually among the period of 20 to 45 years. This is the age factor where iron deficiency anemia is more prone to attack. And most commonly it is also seen in premature infants, which is also one of the etiological agent. And other than that, in childhood and adolescence is also one of the age group which is being seen affected with iron deficiency anemia. The most common features are anemic features. They include the pallor or otherwise that is paleness, yellowing of the skin can also be seen in these patients. Other than that, patient might also complain of weakness, tiredness, and loss of physical activity. Compromised physical activity can also be one of the clinical feature. The other features include the epithelial tissue changes. There is presence of koilonychia. Koilonychia is presence of spoon-shaped nails is known as koilonychia, which is the most common feature observed in an anemic patient. Is most commonly in iron deficiency anemia. Other than that, atrophic glossitis and angular stomatitis are also features. In atrophic glossitis, usually we see that the tongue, there's loss of atrophy of the papilla, and in angular stomatitis, we see radiating fissures occurring from the corners of the mouth, angles of the mouth, which is known as angular stomatitis. Next coming is a Plummer-Vinson syndrome. Usually in these patients we see that there's keratosis, that is koilonychia, glossitis, and other than that there's even postcricoid area, that is esophageal webs are being formed in these patients. So these are the most important clinical features, anemic features, and the epithelial tissue feature changes occurring in iron deficiency anemia. Coming to how the development of anemia, that is how anemia progresses. Initially it is because of the storage of the iron depletion, that is when there is inadequate intake from the diet or otherwise inadequately supported iron being produced from the dying red cells, then the iron stores which are being present in the spleen and liver, they are being utilized. So there's depletion of this iron stores, which might so since these stores are normally being utilized for erythropoiesis and hematopoiesis in the bone marrow, so there will be deficiency of iron in the erythropoiesis because of these iron stores being utilized in dietary intake, and then this iron deficiency results in iron deficient erythropoiesis result in iron deficiency anemia, which shows a proper frank anemic features. So these are the stages, that is the 3 stages of iron deficiency anemia. Next, coming to the laboratory findings, usually patients with iron deficiency anemia show decrease in the hemoglobin content, and the red blood cell count is also totally reduced when compared to the normal individual, and there are even presence of certain reticulocytes in the peripheral blood smear which reflect the bone marrow activity, that is being altered. And the absolute values, that is the MCH, mean corpuscular volume, and mean corpuscular hemoglobin, as well as mean corpuscular hemoglobin concentration, all of them have been reduced. And leukocytes, they could be normal or moderately reduced, and platelet count also is similarly, usually we see that it is being raised in cases of hemoglobin iron deficiency anemia. So these are the certain blood picture and the red cell indices, and usually we find that the marrow cellularity, usually there's alteration in the myeloid erythroid ratio, that is the myeloid series, they usually increase when compared to that of the normal. Other than that, there's also hampered erythropoiesis because of the lack of the sufficient iron in the diet. And the other cells which we can see is in cases is the smear cells which can be observed in iron deficiency anemia. and the marrow iron content is also usually reduced. That is, the iron stores which are being placed in the form of ferritin or hemosiderin as well as this transferrin, all of them are reduced. Coming to the biochemical activities, that is the serum iron level, that is which is being transported or present in the form of transferrin, it is also reduced. Then the total iron binding capacity is usually increased. The serum ferritin, it decreases. Coming to the red cell protoferrin also, it also decreases, and the serum transferrin receptor protein also, they are moderate to normally present in the human blood. So these are certain lab findings in iron deficiency anemia. So this is the picture showing the peripheral blood smear presence of microcytic hyperchromic anemia, which is a characteristic feature of iron deficiency anemia. That is a normal size when compared to that of the red blood cells, that is 7.2 micron diameters, that is reduced. And the staining is also reduced in iron deficiency anemia. It is probably because of the reduction in the heme content. So the treatment, it includes the correction of the disorder. That is, if it is because of inadequate dietary intake, patient is advised and counseled for proper dietary intake, and otherwise if it is because of the improper absorption of the iron, then further treatment for megaloblastic anemia can be done, or presence of vitamin B12 correction can also be done, which results in reverting of the patient to normal condition. Next coming is the correction of iron deficiency anemia with the oral therapy or otherwise parenteral therapy. Usually oral therapy, the patient are given with iron supplements. The oral therapy, it involves oral intake of certain iron salts, which could be a ferrous sulfate, ferrous fumarate, or otherwise ferrous gluconate. These are the iron salts given in the tablet form for the patient. But usually in these patients, we see there are many side effects such as nausea and vomiting, also impaired functioning of the general physiological metabolic functions in the body. So these are the certain conditions which are seen in oral therapy. When the patient is not tolerant to this oral therapy, that is intolerance to oral therapy, then the patient is given iron dextrin, which is given in the form of intramuscular injection. If it is given as a iron dextrin, suppose it is supposed to be given, that is the patient is more showing aggressive anemia, then intravenous injection is given, where this iron dextrin is being diluted with dextrose or otherwise saline, and these are the certain kinds of treatments which are being provided for iron deficiency anemia. Coming to megaloblastic anemia. Megaloblastic anemia, it is usually a disorder which is caused by impaired DNA synthesis, and it is characterized with distinctive abnormality in the hematopoietic precursors in the bone marrow, where the nucleus maturation is being delayed related to that of the cytoplasm. That is, the nuclear maturation lags behind that of the cytoplasm because of the abnormality in the DNA synthesis, which are usually responsible for the hematopoietic precursors to develop in the bone marrow for the further differentiation stages. So the underlying defect majorly for the megaloblastic anemia to occur is the deficiency in the vitamin B12 as well as folic acid deficiency, both of which are involved in maintaining the normal general cell metabolism such as hematopoiesis. And the next underlying feature is because of the interference of the DNA synthesis with congenital or otherwise acquired abnormalities with vitamin B12 or folic acid metabolism, both of them which are involved in maintenance of the hematopoiesis. So these are the underlying defects which are being seen in a megaloblastic anemia. Next coming is to know, since vitamin B12 and folic acid are the most important structures or the factors which are involved for metabolic megaloblastic anemia to occur, it is important to know that what vitamin B12 is. So vitamin B12, it is also known as cobalamin, which is one of the complex of the vitamin B series group. Which is present in two forms. That is methylcobalamin or otherwise adenosyl cobalamin. Both of these are enzymes, and usually the therapeutic vitamin B12 is available in the form of cyanocobalamin. And vitamins, as they are only provided with an exogenous source, similarly vitamin B12 is also provided with by the diet which is being taken. It should be taken in the form of kidney, liver, heart, meat, fish, eggs, cheese or milk. So these are the sources for vitamin B12, and it is synthesized mostly in human large bowel with the presence of certain microorganisms, and it is absorbed at the distal ileum, and it is being stored in liver. So these are the certain major functions of vitamin. And coming to the functions of vitamin, usually it is involved in general cell metabolism, such as hematopoiesis, that is where the blood cells are being differentiated in the bone marrow from the stem cell. And otherwise also it helps in maintaining the integrity of nervous system, where it mediates certain chemical reaction, that such as hypermethylation of methylation process of homocysteine to methionine, which is being mediated by tetrahydrofolate. So this is one of the mechanism. Other than that, there is even carboxylation reactions which are being carried out by cobalamin, and which usually help in maintaining the integrity of the nervous system. Coming to the folic acid, which is also known as folate or vitamin B9, BC, or otherwise vitamin M, or otherwise known as folacin. So these are the certain synonyms of folic acid. It is usually appears as a yellow compound which could exist in a conjugated which exists as conjugated folates, which are being further reduced. That is, they are being dissociated from these conjugates and results in the formation of dihydrofolate forms and tetrahydrofolate forms. And the major source for this folic acid is from the fresh green leafy vegetables, as well as it is present in milk, cereals, meat, and certain fruits. And it is mostly being observed from the diet in duodenum and upper jejunum, and it is being stored in liver and red cells. So this folic acid, it usually acts as a functions as a coenzyme, where it transfers the units linked to the vitamin B12 metabolism. Coming to the biochemical basis of megaloblastic anemia, usually the basic biochemical abnormality which is common to vitamin B12 and folate deficiency is there is block in the DNA synthesis pathway, and there is also an interrelationship between the vitamin B12 and folate metabolism in reactions such as methylation, where they convert homocysteine to methionine. So these are certain factors which these are certain biochemical basis of metabolic megaloblastic anemia. And so the folate dependent reactions for DNA synthesis involves two kinds of reaction. They are the thymidylate synthetase reaction and homocysteine methionine reaction, and these reactions are as follows. First reaction, that is the thymidylate reaction, we see that the formal tetrahydrate folate it is being converted to methylene tetrahydrate folate by releasing certain nitrogen species, and even in the presence of hydroxyl groups. And this methylene tetrahydrate folate is being converted to dihydrofolate in the presence of where this converts the d-uridylate methyl folate to this methylene tetrahydrate folate, it converts to dihydrofolate in the presence of uridylate thymolate, and this dihydrofolate, it is being converted into tetrahydrofolate folate in the presence of NADP, which is required in the form of energy. This tetrahydrofolate it can either be convertible into methylene tetrahydrate folate vice versa. And this methylene tetrahydrate folate can also be converted into methyl tetrahydrofluorate by releasing energy such as NADH, and this methyl tetrahydrofolate is finally converted into tetrahydrate folate, and this cycle usually continues by converting by their vice versa conversions. So the reaction of conversion of methyl tetrahydrate folate to tetrahydrate folate, it also mediates the conversion of methyl vitamin B12, that is cobalamin, to vitamin B12 into an active form. This reaction, it usually mediates the methylation reaction, that is conversion of homocysteine to methionine in the presence of methionine synthetase. So these are certain reactions which are usually required for DNA synthesis and also maintaining of the neurological functions and as well as hematopoiesis. So coming to the etiology of vitamin B12 deficiency, usually since vitamin B12 is being only supplied by an exogenous source, so any inadequate intake of this dietary from the diet, it results in vitamin B12 deficiency. So this could be one of the etiological agent. Other than that, it could also be because of malabsorption in case of gastric cases and intestinal causes, because since it is an area where the stores have to be placed and where the absorption of vitamin B12 occurs. So any condition such as gastrectomy can result in impaired absorption of this vitamin B12 and result in vitamin B12 deficiency. Coming to folate deficiency, it is usually because of inadequate dietary intake, that is in the form of exogenous source such as vegetables, fruits and meat. And other than that, similarly, if there is any malabsorption, that is in case of other nutritional deficiency, which usually mediate this absorption of folate, can also result in vitamin B12, can also result in megaloblastic anemia. Next coming is accessory urinary folate loss. It is usually seen in conditions like heart failures, where there is accessory folate which is being lost in the form of urine, and even in conditions such as excessive demand also this folate deficiency, such as in physiological conditions like lactating mother or a pregnancy female, in pathological conditions such as when there is gastrectomy like conditions, or otherwise in certain malignancies it could also result in folate deficiency. Coming to the other causes, there could be impaired metabolism, that is they have been sufficiently intaken into the body, but rather they are not further metabolized into the byproducts which have to be utilized for the further physiological mechanisms to be undertaken. And next coming is the unknown etiology. In certain syndromes it has been observed, such as in the appearance of megaloblastic anemia as another secondary complication. Coming to the clinical features of megaloblastic anemia, usually the common anemic features can be seen, that is the pallor and weakness, tiredness of the patient, and muscular weakness can also be seen in case of anemic condition. Other than that, glossitis is also a condition where we see it affecting the tongue, resulting in atrophy of the tongue and resulting in burning sensation. Other than that, neurological manifestations can also be seen in megaloblastic anemia. Coming to the laboratory findings, usually we see general laboratory investigations are done, such as the blood picture and bone marrow findings, as well as certain biochemical tests. And the other tests, special tests, they include for the tests which investigate the deficiency of vitamin B12 and folate. Coming to the blood picture or red cell indices, usually the hemoglobin, it is usually reduced, and the red cells, we find that it is they are microcytic and they are macrocytic, that is increased in the size, and hyperchromic. And the presence of reticulocyte count can also be seen, which reflects the altered bone marrow activity because of the deficiency in vitamin B12 and folate, which are usually involved in maintaining the general cell metabolism in the hematopoietic field. Next coming is the absolute values, usually the mean corpuscular volume as well as the mean corpuscular hemoglobin, both of them have been increased, whereas mean corpuscular hemoglobin concentration is being reduced. Coming to the leukocytes, they may be moderate to normally present, and the platelets, they are also they are usually variable in certain conditions. This is a picture showing the presence of Hawley-Jolly bodies which appear as a granularity which is at one pyknotic end. And next coming is a basophilic stippling, that is showing the punctate basophilia, granularity being uniformly dispersed within the entire cell. Next coming is a hypersegmented neutrophil, which is a characteristic feature showing more than 5 lobes of a neutrophil. Next coming is a Cabot ring, showing a uniform dense staining of the entire cell and as well as associated with granularity. And next coming is a macrocytosis, that is abnormal increase in the red blood cell. Coming to the marrow findings, usually the marrow activity, it is usually there's altered erythroid myeloid ratio, and the erythropoiesis, it also shows presence of numerous erythroid precursor cells as they do not differentiate because of the deficiency in vitamin B12. And other than that, there are other cells which are being seen, that is the Hawley-Jolly bodies and the band cells, as well as certain megakaryocytes can also be seen. The major characteristic feature is presence of a hypersegmented neutrophil which can be seen. The marrow iron quantity is also altered in case of megaloblastic anemia, and chromosomal abnormalities such as chromosome breakage or translocations can also be seen in megaloblastic anemia. The next coming findings, biochemical findings, that is the serum unconjugated bilirubin as well as the low density lipids, they are also being elevated in case of the megaloblastic anemia. Other than that, serum iron and ferritin, they are usually normal or otherwise elevated in content in the total serum level. Coming to the test for vitamin B12, that is the special test. Initially starting with the serum vitamin B12 assay, which includes the microbiological assay where the serum of the patient is being collected, and to it certain microorganism strains are being added. Both of them together react and show the presence of certain presence of the levels of the vitamin B12 in case of microbiological assay. Whereas in radioassay we see that there's present of by utilization of certain radioisotopes such as cobalt 58 and 57. These are the radioisotopes which are being utilized, which are once being mixed in the serum of the patient along with certain reagents. Then they result in showing the expression of the vitamin B12 which is present in the serum and which can be further analyzed. Next coming is the most commonly used is the skilling test, which is usually used in 3 stages. It is a urinary excretion test where the patient is advised to fast overnight, and it involves 3 stages. In the first stage, after overnight fasting, patient is given vitamin B12 supplement without any presence of intrinsic factor, and the urine is next examined for excretion for the next 24 hours and thereby it is detected for the presence of vitamin B12. Next coming to the stage 2, vitamin B12 supplements along with the intrinsic factor is given, and then the patient is advised to excrete urine at certain intervals, regular intervals, where the vitamin B12 in the serum, in the urine is being examined for its normal levels. And then stage 3, it is usually a test which is done in malabsorption of vitamin B12, and can also be done when the stage 1 and stage 2 also show normal levels of vitamin B12 to confirm the test. So these tests are this involves a skilling test which is done to investigate the levels of vitamin B12 in the urinary excretion. Next coming the serum enzyme levels. Since vitamin B12 shows it also acts as a coenzyme, the estimation of these levels can also give the diagnosis of vitamin B12 deficiency related to megaloblastic anemia. Coming to the test of the folate deficiency, it is usually done with the help of urinary excretion of the Figlu test and as well as serum folate assay test, which involves further microbiological assay as well as radioassay. And next coming is the red cell folate assay. Coming to the test for folate deficiency, usually it requires urinary excretion of Figlu. Figlu is for aminoglutamic acid, which is usually an acid which is being converted to the glutamic acid in the presence of folate. So this folate is required for the mediation of the Figlu to glutamic acid, and so patients are usually given administered with histidine, since histidine catabolism is being mediated by the conversion of Figlu to glutamic acid. And once the patient is being administered orally with histidine and further checked for presence of Figlu in the urine, this gives one of the diagnoses for presence of folate deficiency in the patient. So this contributes to the urinary excretion of Figlu in investigation of folate deficiency. Next coming is the serum folate assay, where the microbiological assay is done for the growth of certain microorganisms such as Lactobacillus casei. There's requirement of folate there's requirement of the presence of folate for the growth of this Lactobacillus casei. So this could be used as one of the microbiological assay where the patient serum is being used for this growth of the microorganisms, and this could be one of the diagnostic aid for the folate deficiency. Next coming is a radioassay where glutamate tetrahydrofolate is being used, which is available as a commercial kit for the serum analysis of the folate, presence of folate in the serum. Next coming is a red cell folate assay. Usually when compared to the serum, the red cells carry 50 to 100 times more amount of folate. So observing for this red cell folate can also help in identifying the amount of folate which is usually present in the red cells compared to that of the serum, and which could drive to the diagnostic of megaloblastic anemia because of folate deficiency. Coming to the treatment of megaloblastic anemia, usually a patient is advised to take intramuscular hydrocobalamin at a quantity of 1000 micrograms for 3 weeks, and otherwise patient can also be supplemented orally giving folic acid. It is 5 milligrams per tablets daily for 4 months depending on the deficiencies. Coming to pernicious anemia. So pernicious anemia, it involves both the vitamin B12 deficiency anemia as also a characteristic feature. Since vitamin B12 deficiency it is also one of the feature in pernicious anemia, in which there is not enough red blood cells because of the lack of vitamin B12. It is so termed because pernicious anemia because this vitamin B12 deficiency. It could also be because of the lack of production of intrinsic factor. This intrinsic factor is usually present in the gastrointestinal tract, where this intrinsic factor helps in the absorption of vitamin B12 into the body, which is being taken from the oral exogenous source. So presence of intrinsic factor is important for vitamin B12 absorption. So any alteration in the levels of the intrinsic factor can also alter the levels in the, can also result in deficiency of vitamin B12. So they are interlinked to each other. Next coming is the other reason why pernicious anemia could occur is it could be also because of a congenital autosomal recessive form, where there is a lack of intrinsic factor. Without usually intrinsic factor is absent or reduced in the levels when there is any gastric atrophy. But whereas in congenital autosomal recessive forms we see there's no gastric atrophy, but the patient still suffer from reduced or absence of intrinsic factor. So it could be congenital, that is by birth. And the next coming is genetic predisposition. Usually it has been identified in certain conditions, in certain patients, that there is presence of certain antibodies to the antiparietal cell, as well as antibodies to the blocking and binding and blocking antibodies. And so antiparietal cells are the cells which consist of which release the intrinsic factor and help the absorption of vitamin B12 from the body. So any antibodies to this antiparietal cell and even for the presence of binding and blocking antibodies can also result in pernicious anemia. Coming to the symptoms, usually it is a triad of symptoms which shows generalized weakness, sores, painful tongue, as well as numbness and tingling sensation of the extremities. So these are the major symptoms to describe a patient suffering from pernicious anemia. And other than that, we can also be presence of severe anemic clinical features such as paleness, weakness in the patient, koilonychia can be seen, and tiredness of the patient can also be seen. Other than that, nervous system involvement such as dizziness, unconsciousness, faintness can also be given, can also be seen in patients suffering from pernicious anemia. And the other features are easy fatigability, headache, dizziness, vomiting, diarrhea, loss of appetite, shortness of the breath, as well as weight loss and pallor. These are also the clinical features which can be seen in a patient suffering from pernicious anemia. Coming to the most commonly involved oral manifestations, patients might complain with burning sensation, and observation we can see that there is atrophy of the dorsal surface of the tongue papilla. Then other than that, glossodynia, that is difficulty in swallowing, can be seen. Glossopyrosis can be seen, that is there is alteration in the temperature. And the atrophied tongue, as already described, feature of glossitis. And the most common characteristic feature is there is a of pernicious anemia patients is beefy red tongue. This tongue, because of the glossitis and the atrophy, it gives a red appearance, a beefy red appearance. So it is known as beefy red tongue, or otherwise known as ball tongue, because of the atrophy of the papilla. And this ball tongue can also, it has been also termed as Hunter's glossitis or Moeller's glossitis. And the other features, clinical oral manifestations, are small and shallow ulcers on the tongue and loss of taste on the tongue. And there's these presence of oral manifestations they might follow periods of remissions and recurrent attack. That is, they might relapse for a certain period, they might be absent for a certain period and then relapse. That is, then they reoccur. And other than that, there is also inflammation and pale yellowish tinge on the oral mucosa, which is one of the feature of anemia patients. Coming to the laboratory findings, usually the patient is advised for blood investigations, where there's since it's an anemia, there's decrease in the red blood cell count as well as in the leukocytes. And it is a macrocytic anemia which shows the increased size of the red blood cells, and poikilocytosis, that is variation in the shape of the cells, can also be seen. But the hemoglobin content is increased in cases of pernicious anemia, and there's thrombocytopenia, that is decreased in the platelet count. There is also present of Hawley-Jolly bodies, and Cabot string is also one of the laboratory investigation finding which can be observed in a peripheral smear of a blood in a patient with pernicious anemia. Coming to the serum levels, there's presence of bilirubin and antibodies for interferon intrinsic factor can be observed in these patients. The gastric secretions are usually decreased, and observation for the presence of intrinsic factor is done where they are usually present or present, and if present they are decreased in the amount than the normal, and otherwise they can also be absent completely. Coming to the bone marrow activity, it is usually hypercellular, showing increased cellularity, or that is the myeloid and the erythroid ratio can also be increased. Then the patients are advised for supplements of vitamin B12, as already discussed. It could be hydroxycobalamin in the form of intramuscular injections measure with a quantity of 1000 micrograms, or otherwise folic acid administration can also be done. So this is the feature laboratory findings as well as the treatment of pernicious anemia. So there is a picture showing macrocytosis, that is increasing large size of the red blood cells, and presence of gastric, that is the fluorescent color, that is the apple green birefringence, giving because of the presence of parietal cell, gastric parietal cell antibodies in the patient suffering from pernicious anemia, which hamper the production of intrinsic factor in the levels and thereby hamper the absorption of vitamin B12. So this completes the pernicious anemia.